Hi everyone. I hope everybody's still hanging in there and doing okay and everybody's safe and healthy. I'm going to wrap up today. I'm going to hope it does take a while to not only record them but actually to export and upload. So I'm hoping to get at least chapter 6 and 7 up because that will be the last actual just test other than your final you have to take. So, having said that, there are 3 more chapters left, 6, 7, and 8. Even during the regular school year when we don't have COVID-19 going on, it is usually extremely difficult for me to get chapter 8 in and give you a separate test for chapter 8. And definitely with all this going on, it will make that feat even harder. So most of the time I don't get to that anyway, so that's not really much different than the regular school semester, which is fine because that's why we call it a tentative course calendar, and we do the best we can. But I never want to rush through this stuff in the classroom because you don't have the opportunity to pause it, you don't have the opportunity to rewind it and go over it. So in class, I like to move a little slower so everybody can make sure that they have the time to not only absorb it, fill out your study guides, but also to be able to go home and study those. Some of you are still working, so just like myself, so you don't have a ton of extra time. Some of you, unfortunately, may not be working right now if you were working before, and the only upside to that is it may give you a little more time to put in some studying. So again, this is going to be on chapter 6, chemistry. I will put up, hopefully today, the video on chapter 7. And if I'm really, really lucky, and I may, I can get up chapter 8 as well. And so then what will happen is you'll have another test, but it'll only be on chapter 6 and 7. And then the last test you'll have, of course, in lecture will be your final as far as a big test. And you will not have a separate test on chapter 8, but you will be responsible for watching that video, filling out your study guides, studying that material, because some of that material, of course, will be on your final. So you're still responsible, you just won't have a whole separate test to take on chapter 8. So having said that, let's get started. And guys, just remember, if you have any questions, comments, concerns, please, please, please reach out to me. Just remember on the lecture test, due to the fact that I'm not using Proctorio, I thought about using it for my classes. The reason I chose not to is because to get the full real effect past what we already have in place, we already have a log. So I can go on, and I don't trust it 100% or anything, but I do have a log that's produced for each person as they're taking their test, and I can see how long you're taking between questions, if you deviated off of the web page and went somewhere else, things like that. So not everyone has webcams and things of that nature, so doing Proctorio would have been burdensome, and if I'm not going to do it across the board for everybody, I'm not doing it for anybody. So the way I can try to, because giving you guys the ability to do yourself a disservice by, for lack of a better word, cheating, and I know you can't stop all of that when you're at home, but the barriers I do have to that, because again, you're just doing a disservice to yourself, because it means you're not taking the time to study the material and learn the material, which is really just only hurting you. And then it's not fair to the people who take it serious enough to really study and are on the honor system. So what we do is we time our test, and I base that off of how long it took you guys to take it in class, and then from our logs, I can see how long it took each person to take it. I compare it to the grades that you were getting on test when we were in class. And from those, I can tweak the time and based on the results I get from those logs. So I really do a lot of digging into the data on our test that we did online. And I will look at this last test we took and look at that data. And if I see that I need to, I can adjust the test that you'll take on chapter 6 and 7 accordingly. So, but if you have any issues or anything like that, please reach out to me, okay? But we do lock those questions. So once you answer that question and you move to the next question, you can't go back to that question, okay? And it is timed, okay? And as you already know, but again, if y'all have any questions with that, please reach out to me, okay? So we're going to run through these slides relatively quickly because that's something I wouldn't do in the classroom, but this gives you the opportunity in this format to be able to pause it, read the screen, go back, listen to what I said again. Of course, look at your textbook, fill out your study guides, and then begin to study, okay? And make sure you're also, because everyone should have their textbook, so make sure that you're looking at that as well. Okay, we did any of these slides because we're not in classroom, and I'm going to skip through these because these are review questions that you would have done for a test that a lot of you have already taken. So I'll go through these, but these are helpful to have if you haven't taken the test yet. Also, they're helpful for your final. So I'm just going to slowly go through them, and this will be a helpful tool for you guys when you're studying for your final. Okay, so again, guys, you have the ability to pause this. You can get out a piece of paper. When your question comes up, pause it, write down what you think it is, go forward, so you can double check yourself and see if you're putting all these pieces together and if your studying is going in the right direction. So please take the time to do that. These are our learning objectives. Again, like I've said before, I'm not going to read these to you. And the reason I can get this stuff out a bit faster is because in class, we would have went over those questions one by one, giving people the opportunity to answer them so you could kind of see, I could see where you were and you could see where you were. Okay, so chapter 6 in your textbook, it's on page 144, 145. That 144, 145 is the first of that chapter. The objectives are up there. There's a list of key terms, which you have in your study guides as well. Abbreviations. These are really, really important, especially for medical assistants, to understand and know all these abbreviations, for lab assistants as well. For medical assistants and lab assistants, these key terms, it is critically important that you understand and know all the key terms. So go over your learning objectives. That's what we're going to look at today. Okay? And so I'm going to, again, quickly go through these key terms. There's quite a bit more in your textbook, but these are the ones that you really need to hone into for chapter 6. So as you can see, we talk about ions and things of that nature, and then we talk about what is a diagnosis based on the patient's initial signs and symptoms. That's a clinical diagnosis. And then what is the final confirmed diagnosis based on the clinical signs and symptoms and the results of the diagnostic test called? That's a definitive diagnosis. So you guys know as medical assistants, a patient may come in, you take their history and physical, you write down all their symptoms, you weigh them, take their blood pressure, their temperature, all these things go together. That's why it's so important to talk to your patient, to listen to your patient. So that it's giving a diagnosis is putting a puzzle together. And not only do we need to use that history and physical, talking to our patients, listening to what they're telling us about their diet, about their weight, about their symptoms. Do they feel sluggish? Do they have trouble sleeping at night? Are they not sleeping well? All these things are vitally important for really great health care and taking care of your patient. These are things that you need to do in that original clinical diagnosis. And then, of course, from there, we're making somewhat of educated or scientific guess on what could be wrong with our patient. So then we may order laboratory tests, we may order ultrasound, MRI, things of these natures to then come to that definitive diagnosis. Also make sure that this next question, what is a form of arthritis caused by the accumulation of uric acid crystals in the synovial fluid called gout? Especially medical assistants, you really need to, you're out there, you're taking care of these patients. You're a part of that healthcare team along with lab assistants, phlebotomists, respiratory therapists that are working together to help diagnose these patients. And understanding that gout is a form of arthritis and it is caused by this specific thing, the accumulation of these uric acid crystals in that synovial fluid. And so we would treat gout different than we may treat another type of arthritis. So that's why it's important for you guys to understand and know these key terms. Insulin resistance. Okay, this is a big deal. We have a lot of patients out there that are pre-diabetic because of their diet and lifestyle. They move very little. They're carrying an excessive amount of weight. Some of them are morbidly obese. They've been eating bad and not moving for years, and they have become insulin resistant. So it's not so much that their body's not producing insulin. It's almost as if the body really just doesn't even know how to use the insulin. The insulin's not able to do its job any longer. And this is something that's vitally important in catching pre-diabetes, catching people before they're in full-blown diabetes, to see if we can help alter some of their lifestyle choices so that we can get them back on track, a more healthier, whole food, plant-based diet, get them moving. Walking is a great way for people to start getting out there and not only increasing that step count. You know, we'd like to see people get, 12,000 steps in a day, and start out slow, get out there walking, talk to your doctor on that, but do these things that can try to prevent you from going in to diabetes. That's why it's important that you guys know and understand what these key terms are, because you're in there with those patients trying to help them, health care. We want to get them healthy, okay? So moving on, you guys really need to pause this video and make sure that you know each one of these key terms. Okay, so an overview of clinical chemistry. Okay, clinical chemistry is the testing of the chemicals, which we call ALHT, that are found in various body fluid specimens. Okay, when we've looked at these in our lab, we've talked about urines, whole blood, then the serum and plasma, which is left once we spin that down and take it off of the cells. Synovial fluid, we talked about that earlier, that come from the joints. Pleural fluid, which comes from the chest cavity. Pericardial fluid from the sac surrounding the heart. And then you have peritoneal fluid from the abdomen cavity, and then we have cerebral spinal fluid. Okay, the specimens most commonly tested in the ambulatory setting, which most medical assistant and a lot of lab assistants will be working in, is usually urine or blood. Sorry about that, guys. So chemistry tests detect and measure chemicals in the plasma and many other body fluids, in the urine, in the synovial fluid, right? Okay, so here's a blood plasma composition flow chart, okay? Now, plasma, you know, we understand that it's 90% water, but there's other things, and you'll see these listed out here. Everything from salts and electrolytes all the way down to hormones and enzymes, and of course there's waste in there, like uric acid and creatinine. And then there's also proteins, right? Everything from albumin all the way over to our clotting proteins in fibrinogen and prothrombin. And then from our globulin, we go down into our immunity or antibody protection from the alpha, the beta, and the gamma. So this is a really good flow chart. And if you look on page 145 of your textbook, it breaks it down. It talks about the nutrients, the waste products, the hormones, enzymes, everything. And so it's a real good, if you read this chapter, it's really good. Also, this exact flow chart, which may be a little clearer to you, is also on page 146 of your textbook, okay? So, reference laboratory specimens. As I said, blood and urine are the ones that most of the time medical assistants would be the specimens that you would be dealing with in a physician's office lab. Sometimes the labs are a little bit bigger and you may be using some venous blood, but for the smaller labs, it's usually capillary specimens and urine. But when we talk about the type of specimens that are usually sent to a reference lab for chemistry tests, we're talking about red top serum tubes that clot, right? Okay, they don't have an anticoagulant in these tubes to prevent them from clotting. Now they do have, because like I told you guys before, anything that is inside that tube is an additive, okay? So the glass red top tube has no additives, but the plastic red top tube has that silica, which we looked at that in lab before. It's that whitish powder that's surrounding the inside of the tube. You can see it, and that silica is in there to help speed up clotting, because one of the issues when we're talking about lab tests is turnaround time, right? We want to try to get these test results out as fast as humanly possible without skimping or cutting corners on doing the stuff correctly and in the right order, right? So an additive that speeds up the clotting of blood is also is also referred to as a clot activator. So make sure you understand that key term there, that clot activator. So that red top tube usually just has that plain red stopper on it, and you can tell the difference between that glass tube that has nothing in it that we use for other things sometimes other than drawing blood in, because it doesn't have anything in it, like putting our microhematocrit tubes into and then labeling the outside of that red top tube. It's used as a discard tube when you need a discard tube. Reason being, it's for the same thing. The glass red top tube doesn't have anything in it, okay? So the SST tube, and you know, we talked about this in lab, and it's on page 147 of your textbook as well. You know, it has that serum separator in the bottom. That's one way that you'll know that's the SST tube. The top on them can be anything from that gold tube to a tiger top tube, which would be a swirl of a black and a gold, or a black and a red. So any one of those that has that, and you see it there, that gel in figure A on your textbook, and it's over to your left, right there, that blood has not been spun down yet. And you will notice that the gel is right down here at the bottom, okay, right here in this area. And then this is your cells that there's a big, nasty, gross clot in there, and those are those cells right there that have clotted all together, and they've kind of settled down close to that gel. And then out here starting to already kind of separate is your serum. And remember, it's serum when the tube clots. It's plasma when the tube does not clot. In a tube such as a lavender top tube that has an anticoagulant in it, such as the EDTA is the anticoagulant in that lavender top tube, then when you see that amber straw colored liquid start to separate at the top, that's plasma, because it still has those clotting factors in there, the platelets are still in there, the white cells are still in there. But when we're talking about a tube that doesn't have an anticoagulant in it, like this SST tube, those white cells and platelets and all those clotting factors get mushed all together in that nasty clot that is there, right? And then over to your right next to that is the SST tube once it's been spun down. And we talked about specific gravity, the specific gravity of the gel material, the specific gravity of our packed cells and that clot, and the specific gravity of our serum are different. And it's set up that way so that the gel itself is able to rise above the cells in centrifugation, and it situates itself between that clot at the bottom of cells and the serum at the top, which is really helpful because we know that if we let that serum set on top of that clot, then it could hemolyze, because it could show some hemolysis, because the red cells will start to break down and release all that potassium into our serum, which will falsely elevate our potassium. It will falsely lower our glucose results because those cells are still trying to use that glucose as a fuel source. So also a green top tube for panels. The green top tube is favored. We talked about this many times in class because of turnaround time. Any stats that are ordered, because you don't have to wait on that green top to clot, right? Because it has an anticoagulant. It has sodium heparin, ammonia heparin, and lithium heparin. One of the three is in that green top. And so you don't have to sit around and wait 5 minutes, 15 minutes, 30 minutes, or an hour for that tube to clot, depending on what type of red top or SST tube it is, if it does or does not have a clot activator in it, for you to be able to spin it down, get your serum or plasma off, and be able to run your test. So think to yourself, what is when we spin it down, what's at the top on the green top tube? Is it serum or is it plasma? So make sure you understand that. Then we have a gray top tube, and we've talked about this before. That's the best tube for glucose tests because they have a preservative. The preservative in that gray top tube is sodium fluoride, okay? And that helps preserve that glucose. So make sure we understand what additives we've talked about so far. So we talked about the clot activator, right? Which is that silica that's in a plastic red top tube. We've talked about sodium fluoride, which is a preservative that's in the gray top tube, right? And we didn't necessarily see it on the slide here, but I talked about the fact that we have an anticoagulant in that green top tube. So here's one of those thinking slides, and I'm not going to say this every time so we can move along, but when these slides come up, pause them, take out a piece of paper, and start seeing if you're answering these things correctly. And guys, make sure you're looking at your textbook, okay? So those pictures that we looked at just now, they're much bigger and better, nicer pictures on page 147, chapter 6 in your textbook, and there's a lot of great information. Make sure you're reading through that, okay? Okay, we're still talking about specimens that we would send to a reference lab, okay? Because as a lab assistant and as a medical assistant, it could be part of your job to draw blood that you run in your physician office lab, but also it could very well, especially for lab assistants working in a hospital, it could be very well be a big part of your job to package up the specimens that are not done in your hospital, because there's a lot of tests that are not run even in the bigger hospital labs, and they must be packaged appropriately and sent off appropriately to the reference labs. So now we're talking about these things we need to know, because it's important to understand that, and you write your time down when you drew that specimen. So let's look at how long do we need to wait for each tube before we can actually spin it down. And we have to abide by these rules. It's vitally important that we wait the time before we spin it down, or you're going to have a big fibrin mess up in your serum, and you won't even be able to pipette it off to send it out. And now you're going to have to redraw that specimen, and nobody wants to have to go back and restick a patient, okay? So glass red top tubes, there's nothing in there, so it's going to take anywhere from 30 to 60 minutes for them to clot. And we give you varying numbers because it depends on the individual. Not every individual is the same. Some people are going to clot quicker, and that blood will clot in 30 minutes. Some individuals, it may take longer depending on what type of medications they're on, what underlying health conditions they may have. So that's why you have that 30 to 60 minutes instead of just one set time. The plastic red top tube and the SST tube, and remember we talked about that clot activator that's in there, that silica. So it could be anywhere from 5 to 15 minutes, and you see that big difference. That's why when you're talking about turnaround time, if possible, you know, and you have to draw it in if you can draw it in an SST or a plastic red top tube, you want to choose that for turnaround time. And then we have red or gold micro containers, a little small containers that we use when we do finger sticks. It only takes a minute to a minute and a half for those to clot because it's a much smaller amount of blood, right? So we talk about how long should a tube be spun down in a centrifuge prior to separating the serum into another tube, right? And that's part of that specimen processing that a lot of lab assistants are going to be doing and medical assistants will be doing. So you need to spin those tubes down for 10 to 15 minutes. And a lot of times your lab will have a set protocol, so everybody's doing it the same way. A lot of times it'll be 15 minutes. They'll say, we're going to spin all our tubes down for 15 minutes. Okay, so make a note also that all tubes should be filled at least 50% full, except for, and we discussed this before, the light blue top tube that we have for our coagulation studies, and then our purple top or lavender top tube, which we use for a lot of hematology things, tests, and that needs, both of those need to be at 100%. So here's a case study, these are one of our higher learning things. This is where you take all the stuff you learn in lecture, all the stuff you learn in lab, you put them together so that you can critically think through things that you may run into actually out there in the field as you're working. Because what we want to do is prepare you guys with these simulations so that when you get out there and you face these things, you will already have been through it in a simulated type activity in the classroom. So read through these case studies, pause them, get out a piece of paper, like I said, write down your answer, and just see, are you putting this stuff together that you're learning to be able to think through it? If you run into any problems, answer, because of course I'm not in the classroom, so I can't help you guys out right then and there, but please make a note of that on your piece of paper, email me, we can figure it out, okay? Okay, so it's a red micro container. Why? Okay, so it says Sam Smith presented to the clinic where you work with a gash to the leg where he cut it with a chainsaw. The doctor ordered a stat potassium. Which of the following would be the tube of choice for drawing the man's blood? We chose the micro container. Why? Because it takes the least amount of time to clot, right? Minute to a minute and a half. And if these are our options, we don't really, if somebody's bleeding, we don't want to wait 30 minutes to an hour. We really don't even want to wait 5 to 15 minutes. So that minute and a half, we can run our potassium quickly, get our doctor our results. That really is your best option if you have it. Okay, so here's our next one. Okay, so we're still talking about reference laboratory specimens. So when you're talking about packaging these things up to send them off to a reference lab, they're going to have paperwork, requisitions, they're going to have detailed information given to you so you will know exactly what needs to be done, and make sure you're referring to those requisitions so you will get the proper tube requirements. Because they may be different than what your particular facility uses regularly. Some specimens may need to be refrigerated. You need to be aware of that. Some should not be spun down and separated from the serum or the plasma, and various panels are available for ordering groups of tests. Okay, so make sure you're familiar with whatever reference lab your physician's office lab is using. Make sure that you refer to their information so you'll be doing it the way you want to, or again, you may have to go back and redraw that patient, and that is the last thing we want to do. So now moving on to talking about physician's office lab specimens for CLIA wave chemistry test. Another helpful thing is on page 148 of your textbook. There's a copy. It's a sample lab requisition that shows the required patient information for this. It shows the test that could be ordered, divided into panels. That kind of helps you individual test and alpha test, and the codes for the colored tubes at the bottom left. Okay, so this will be something to be helpful for you. There's on 149, there's a comprehensive metabolic panel that kind of tells you what the CPT code is, the tests that are in it, type of specimen, amount. These are just some really good information. It's very helpful to you. The textbook has a lot of really good information. So guys, please make sure you're reading your chapters as well as watching these, as well as going through your study guides. Okay, so what type of specimen is usually used for CLIA wave chemistry tests performed in the POL? And we talked about this many times. Capillary blood from skin punctures is collected into the various testing devices is the most common. Especially the smaller the physician's office lab, the more likely it is that they use capillary blood. The instruments for this are less expensive. They're weighed, so you don't need medical assistants, lab assistants, and phlebotomists even can be trained how to properly operate these instruments. And so it is a very cost-effective way for a physician's office to have a lab there and to be able to get results quickly so that he can better diagnose, monitor, and treat his or her patients. Whole blood in anticoagulated tubes as recommended by test method. So again, you always want to be familiar with any package inserts, with any of your kits, any of your testing instruments. You want to know what that manufacturer says is the best thing to be used for that particular instrument. A lot of times, this is just some helpful stuff for you. The green top tube that we talked about earlier, it's great for turnaround time. It's really good for lipid profiles. That gray top tube is really the gold standard for glucose. And that lavender top tube or purple top tube is known for hematology tests like CBCs and hemoglobins and hematocrit, but it is also the tube used for the hemoglobin A1C, which is really the best test and the test they use most often when we're talking about diabetes mellitus. So glucose metabolism and testing, okay? So there's some really good information inside your textbook also on glucose metabolism. So make sure you're reading that, starting on page 149 down at the bottom. So in the ambulatory care setting, the most common CLIA wave chemistry tests are designed to screen and monitor glucose and lipid metabolism, right? So what happens during the digestion of your carbohydrates? Now, be careful because, carbohydrates are not the devil. You need carbohydrates, to survive, but you just want to know the difference between a really good carbohydrate that is good for you and it fuels your body. And as this picture right above us with those McDonald's French fries, guys, as good as they may be, you don't want to eat anything that can stay alive and look exactly the same way it did the day they gave it to you 6 months later laying in the bottom of your floorboard. And this hamburger, these type of carbohydrates are not the carbohydrates any of us need to be eating on any type of regular basis. Also, take into consideration, carbohydrates, like all our calories, are broken down, they're fuel. Well, if you're not moving, if you're not getting 12,000 steps or more in a day, if you're not exercising on a regular basis, if you sit behind a desk all day in your job, and then unfortunately when you leave work, you drive everywhere you go, you don't walk, you don't ride a bike, you don't exercise at all, then your body doesn't need all that fuel, whether it comes from carbohydrates, fats, or protein. And what's it going to do with it? If it doesn't use it, it's going to store it. And that's how we gain weight and become obese, and it can lead to morbid obesity and heart disease and diabetes mellitus, right? So carbohydrates are broken down into glucose, which is sugar, right? And that enters our bloodstream, okay? So from the bloodstream, glucose enters the tissues, right, with the help of insulin. And then it's used for energy. And remember, we can store, some of our storage of energy can be stored in our liver and our muscles, so that when we get out there and we go for a walk, or we ride our bike, or we do a workout or whatever, it can bring it out of that liver and that muscles and use it for that quick energy that we need. But if you're taking in more than you need, it's going to store it in that adipose tissue as fat. And insulin is what helps us move it from our bloodstream into our tissues. So that's why when we talked about insulin resistance earlier, that's why we talked about how that is pre-diabetes, because when you're not able to move, when you're not either not producing enough insulin or you're not responding to that insulin properly, then your body is now not able to get that sugar out of your bloodstream into the tissues. And what happens is your blood sugar levels go up. And the reason we run into that when we are overweight is there's a lot of mechanisms out there, okay? It's very complex, but when you have a lot of stored fat in your liver, in your muscles, in your adipose tissues, sometimes there's just nowhere for it to go, and your body can't figure out where to take it any longer, and it builds up in your bloodstream, okay? So the question is, what happens when excess glucose is taken in? Okay, and this is what I was talking about, that excess glucose is stored in the liver and in the muscles as glycogen, right? And it's combined with fatty acids to produce triglycerides, which is what we don't want, and is stored in that fat and adipose tissues. But what happens is when you're taking in all these carbohydrates, all these fats, all these proteins, way more than you need for your energy levels, and you've stored all the liver can hold, you've stored all that the muscles can hold, it has nowhere else to go but into that adipose tissues. So the storage form of glucose that we talked about, what we store in our liver and our muscles, which only a certain amount can be stored in that liver and muscles, is glycogen. So why is glycogen stored? Where? And we talked about that, right? In the muscles and the liver, right? Okay, so do this homework, because you're going to have this in your sheets that when we were sitting in the classroom, you would have those sheets in front of you, and as we were lecturing, you were filling out these study guides, and then you would use those study guides along with the things that you learned in lab and your textbook, and you would study and take your test. So right here, this is something that you would want to be able to do. You want to be able to describe in your own words why people gain weight when they eat too many carbohydrates, okay? And when they, especially, guys, if you yourself are wanting to help yourself, make sure you look up and find out from reliable sources what are the good and healthy carbohydrates and what are the carbohydrates you want to avoid. We need carbohydrates, but we need to make sure that we're not eating a bunch of especially bad carbs that have no fiber in them, and then we're not moving at all, okay? So again, like I said, carbohydrates are not the devil, but we do need to understand that how it works in our body, and if we're taking in too many, what can happen. So make sure your answer contains that carbohydrates are broken down into glucose in the body, and that excess glucose is stored as fat. That's the takeaway from this. That's what you want to understand. So, still talking about glucose metabolism, okay? And as a medical assistant, it is vitally important that you understand this mechanism. But honestly, all of us, all individuals need to understand at least the basics of how glucose metabolism works for our own health. We should be the stewards of our health. We cannot depend on just our physicians, just our physician's assistant, nurses, doctors, all these people to dictate to us what we need to do. We need to understand this so that we can make sure we're healthy. Because as I'm sure you guys have been hearing, and I'm sure you guys know this, and you're learning this as you go with all the classes that you're taking, but these people with underlying health issues like morbid obesity, heart disease, COPD, emphysema, all these things that lead to other health problems, decrease your immunity, decrease your strength, your cardiopulmonary because you're not moving. These are things that leave you vulnerable to things like COVID-19. That's why the people that are dying are the people with these comorbid conditions that have left them weak or left them not as healthy, and that's what causes problems. So take control of your health, okay? And we want to walk the walk and talk the talk, right? So when you're out there trying to convince your patients to get healthier, to eat healthier, to move, to lose weight, they look at you, and if they're like, they can't even do it, why should I listen to them? So make sure that you first start with yourself and make sure you understand this stuff really, and make sure that you're implementing it into your daily life. We all need to do this so that we will all be healthy, okay? So we're talking about the roles of the hormones, both insulin and glucagon, right? That's our two hormones, okay? And they're produced by the islets of Langerhans in our pancreas, right? And so we talked about this. Insulin is our hormone that goes out there when we eat a big meal, especially if we go out and eat pancakes smothered in a syrup. Our insulin goes, oh no, let me get out there. I need to get us back to homeostasis, right? So I need to get that sugar level back down to our normal range, and I need to move it into the tissues. And we know if we're exercising on a daily basis and we're depleting that stored glycogen that's in our liver and our muscles because we're moving every day and we're exercising every day, then that's where it's going to want to take it first, right? That insulin's going to come in, it's going to take that extra sugar and stuff we have, it's going to turn it into glycogen, it's going to store it in our liver and our muscles so that tomorrow, because our body knows, hey, tomorrow she's going to be walking a lot, he's going to be working out, we're going to be riding bikes. We're going to need that for fuel, right? Then we have that glucagon, which raises our blood sugar. So let's just say we eat that breakfast, okay? We worked out the day before, so our stores are low, so our body's able to produce that insulin. It breaks it down, turns it into glycogen, stores it in our liver and muscles, and we're watching our calorie intake, right? It's not as simple as calories in and calories out, but it is important, right? How much calories you consume versus how many calories you burn, okay? And most of us would be shocked, okay, at how many we're actually putting in our mouths. So now you've stored that sugar as glycogen in your liver and your muscles, and you're sitting behind a desk all day, but you're making sure you get up every little bit, and you walk around your building. When you get off work that evening, you were real careful what you ate for lunch, low calorie food, healthy food, right? Nutriently dense. You took a light walk at lunch. You made sure you walked as much as you could throughout the day. You got off work, took your dog for a walk. You might have went to the gym and did a light workout. You might have ran. You might have rode your bike. You might have did a home workout. And then you went, and then as the day was going on, you got busy. You didn't take in a whole lot of calories because you're trying to watch that, right? Well, then that's when the glucagon, your other hormone, comes up, and it takes that glycogen that's stored in the liver or the muscles, and it brings it out and puts it back into the bloodstream because your blood sugar was dropping, right? Because you hadn't ate a lot and you've been moving around a lot and you've been burning calories. So now you need that glucagon to get that blood sugar back into your bloodstream. So you can see how these are antagonists to each other, right? And we need a really good balance of getting that excess sugar out of our bloodstream to keep us at a normal limit. But when we need some more sugar and we would rather use that stuff that's stored either as glycogen or honestly as that fat that's stored in our adipose tissue, to burn that. So this gives you kind of a better idea of why people have a real issue with maintaining or losing weight. A good study tip is to think about call on glucagon, G-O-N, gone, right? When glucose is gone. So when your blood sugar levels drop below normal, glucagon is the hormone that's going to pull that stored glycogen out, produce it back to sugar, put it into your bloodstream to stabilize your blood sugar. And then when your blood sugar is too high, you're going to produce that insulin, which is going to take it out of your bloodstream and put it back in a storage area in your tissues, right? So go through these questions, pause them, write them down, make sure you're understanding the difference between glucagon and glycogen. So now we would have done this in class, but honestly, we can't do it in class, right? So this is something, if you have somebody in your house that if you're bored, you could do this, but it's really just a fun activity to kind of give you the idea of that antagonistic play between insulin and glucagon and why it's so vitally important to make sure you're tracking the calories you're taking in on a daily basis. You need to know, hey, what's my resting metabolic rate? How many calories do I burn just at rest, okay? And it's usually not nearly as many as you think. There's calculations online you can use. Of course, they're not as accurate as having that tested, so you will truly know how many calories you just burn at rest. And remember, the more muscle mass you have, the more muscles you have, the more you burn at rest. The less muscle mass you have, the less you burn at rest. That's why it's important for all of us to do some resistant training to make sure we build up some muscles. I'm not saying Arnold Schwarzenegger muscles, okay? But to build up some muscle mass because, hey, more muscle mass you have, you're just sitting around, you're burning more calories, right? So you need to know how much you burn at rest, and then you need to track how many calories you're taking in daily. Now, it's a big job to do that at first. If you can do it a few times, because most of us eat a lot of the same things, you can get a real good idea of about how much calories you're taking in from the things that you do. And then you need to track how many calories you burn in a day. That'll give you a real good thing of calories in, calories out, which I understand it's not quite that simple, but that's a good way to start so you can see where your holes are so that you can actually get and maintain a healthy weight. It's vitally important. Okay, here's another one of those homework things that I need you guys to write down. And you're just going to describe in your own words why the hormones insulin and glucagon are considered antagonists. Make sure your answer contains an antagonist is something that works in the opposite way from something else, right? They go against each other. So insulin lowers your blood sugar levels, glucagon raises your blood sugar levels. So still talking about glucose metabolism, and like I told you, there's a lot of really good information in your textbook starting at the bottom of page 149. Okay, there's some really great pictures that you can easily look at that will help you understand the process, and there's really just a lot of great information in your textbook. Okay, so how does glucagon from the alpha cells of the pancreas increase glucose? By converting glucagon, which we remember we had that stored in our muscles and our liver, we convert it back to glucose, right? By converting non-carbohydrates, proteins, and fats into glucose, right? Okay, because we can produce that as well. Okay, so how does insulin from the beta cells of the pancreas reduce plasma glucose? By moving glucose into all tissue cells, right? storing excess glucose as glycogen in the liver and muscles, and by storing excess glucose as triglycerides in the fat cells. So now we're talking about glucose metabolism still, and if you'll see right there, that's a AccuCheck machine, which is a handheld glucose machine. It's a real game changer for diabetics to help them monitor their glucose levels, right? So in these reference ranges will fluctuate from state to state, region to region, but these are pretty close. So what must the glucose levels in the bloodstream be to maintain, to keep that body in homeostasis? So we're looking at those antagonists doing their job to keep us at about 70 to 110 milligrams per deciliter. So what is a reference range for a fasting glucose test? Again, 70 to 110 milligrams per deciliter, right? Because insulin will keep us within there. So if it gets up above 110, that insulin's going to do its job, move it out of the bloodstream into the tissue cells so that we can maintain it. If we're moving around a lot, we're exercising a lot, we're using up it, and we haven't eaten a lot, so we haven't replenished it, and our blood glucose levels start to drop below 70, then it can produce the other antagonist to go out there, that glucagon, to go out there and then cause us to be able to pull that glucagon out of the liver and the muscles and turn it into glucose and put it in the bloodstream to get that that blood sugar level back to normal. Okay, so here's another one of our higher learning activities. Okay, so you guys pause this, read over it, and make sure that you're putting together everything you learned to be able to critically think through these things when you're out there in the field. Okay, so in our textbooks on page 150 down at the bottom, it starts talking about diabetes mellitus. Okay, and we understand that diabetes mellitus, sometimes called DM, is a disorder of carbohydrate metabolism, and it's characterized by hyperglycemia, which is elevated blood sugar levels, and glucosuria, which is sugar in the urine, resulting from the inadequate production or use, remember we talked about that, of insulin. DM occurs when the pancreas is unable to produce enough insulin to move the glucose from the blood into the body cells, okay? So we have two types of, well, really more than, but two types, okay? Describe diabetes mellitus type 1, or it's referred to as insulin-dependent diabetes mellitus, IDDM, right? Insulin-dependent diabetes occurs in about 5% to 10% of the diabetic population. It's the result of an autoimmune disease, okay? And it destroys the pancreatic beta cells. So this isn't really attached to lifestyle, okay? We're not really sure yet. We wonder if something in the environment could be the cause, but there's no definitive answer at this time. There's a lot of research being done on it, but there's no real definitive answer, okay? But it is more the result of an autoimmune destruction. You see your beta cells of your pancreas as some type of enemy, or you have an issue with them, and you destroy them, which they're then unable to produce the insulin, right? So without insulin, the body cannot move glucose out of the blood and into the tissues, right? So consequently, those patients with IDDM must constantly monitor their blood sugar levels and inject the appropriate amount of insulin to prevent the harmful effects of hyperglycemia, right? So the high points on this, usually it occurs in younger people before the age of 30. A lot of people I know that have been diagnosed with it were even under the age of 20 or in their early 20s, right? It's a very abrupt and rapid onset. There's little or no insulin production because of the destruction of those cells. Different from type 2 diabetes, they're usually thin or normal body weight. They usually go into ketoacidosis, often occurs. They have polyuria, which is excessive urination, polydyspnea, polyphagia, and they're usually treated with insulin. So make sure you read through that in your textbook. It goes into a lot of stuff about cardiovascular problems, microvascular problems. It goes into ketoacidosis, which is a very dangerous condition that could lead to diabetic coma. Okay, so make sure you read through all of that, guys. So what does diabetes mellitus type 1? Okay, and we talked about this, right? We talked about the autoimmune destruction of the cells. We talked about having to inject insulin. We talked about the more severe problems with, like I said, the microvascular problems, the cardiovascular problems. You know, it can lead to kidney disease and renal failure. It can lead to blindness and poor circulation. It makes the heart vessels more prone to formation of fatty plaque along the inside of the walls of the arteries. And it could lead to atherosclerosis, heart disease, hypertension, and strokes. Okay? And then we talked about that ketoacidosis being a very dangerous condition. Okay? Because that insulin is not present and the cells do not receive their glucose. It is a result of the body's effort to obtain its energy from fat rather than glucose. Okay, the byproduct of the fat breakdown are ketones, which eventually make the blood dangerously acidic. Okay, and when blood becomes acidic and glucose levels are excessive, the patient may become comatose. Okay, so individuals with IDDM, they really rely on monitoring their blood glucose levels several times a day to keep levels down. With any type of diabetes, diet, exercise is vitally important. Watching what you eat, a whole food, plant-based diet, getting exercise, these things are great for all of us, but it's really important for IDDM, and also checking their blood sugar and administration of their insulin. Okay, so then we have type 2, or what they refer to as non-insulin diabetes. Now this is really important to me because this is the thing that led me into community and public health. After working in a lab as a medical laboratory technologist, I owned my own durable medical equipment company with some business partners, and I did a lot of the coding and billing and medical review of medical records. And we got this has been several years ago, but we got some information coming in from the CDC and from health and hospitals talking about the fact that we used to refer to type 2 diabetes and non-insulin diabetes as adult onset diabetes, because we almost exclusively saw it in people over the age of 30, over the age of 40. Okay, but we got a letter one day saying that we no longer wanted to refer to it as adult onset diabetes because children were now getting it. And I can honestly say, all those years that I was in the hospital, all those years I was in clinics, and the years that I owned my durable medical equipment company, I had seen the ravaging effects of type 1 and type 2 diabetes on people. And it really scared me to think of what would happen if large swaths of children in a big population were to start developing type 2 diabetes at 10, 12, 15, what was going to happen. And of course, those warning signs were there. I mean, we started seeing the increase of obesity across the U.S. We had a obesity epidemic, literally, in the States. And so it was causing a lot of other underlying health problems, like I discussed earlier, from heart disease to cancer to kidney failure, COPD, emphysema, just us living a very unhealthy lifestyle and just so many increased risk of disease from smoking to diet to inactivity. So that's one of the things that led me into public health, and it is a public health problem because type 2 diabetes or non-insulin diabetes is really a lifestyle problem and can be changed. So to hit that, and like I said, in page 150, it talks about non-insulin dependent diabetes mellitus. And when I was stumbling over earlier, there's 2 types of diabetes. There are, but there's also, those are the big ones that we think of most of the time, but there are still others. There's pre-diabetes, that insulin resistance I talked about, and there's also gestational diabetes that we'll talk about, okay? So, like I said, usually type 2 occurs after the age of 30. It's a gradual onset. That's why you go through the pre-diabetic stage. It takes years of not moving and eating and slowly but surely just putting on more and more weight, losing more and more muscle mass, okay? The insulin is usually present, but it is either you're just resistant to it and it can't do its job any longer. And then 85% are either, usually with pre-diabetes and insulin-resistant diabetics, you see them overweight. You know, you're talking about 20, 30 pounds overweight. When they move into the fact that they're on metformin, or sometimes they even move to the fact that they have to be on insulin, a big portion of those are obese or morbidly obese. Ketoacidosis, it's not that it never occurs, but it seldom occurs. And then you still have the polyuria, polydyspnea, polyphagia, or sometimes occurs. This really can be treated with diet and exercise. You may have to originally be put on some type of oral hypoglycemic or insulin, but if you really go after a whole food, plant-based diet, if you really look at getting up and moving and losing that weight and strengthening your heart and your cardiovascular system, if you look at building some muscle, if you really do the things that you need to do, you can come off of those medications and insulin if you really work at it. So what diabetes mellitus, type 2 or non-insulin dependent diabetes mellitus? Okay, so with it, okay, what happens? The impaired glucose tolerance, okay, those beta cells have periodic release of insulin, resulting in episodes of hypoglycemia and hyperglycemia. And then you have the insulin resistance, that inability of insulin to move glucose into the body cells, even though it's out there. And then you have non-insulin dependent, usually controlled by diet, okay? So make sure you're looking through this. Make sure you're reading this information in your textbook and filling out your study guides and studying those study guides, okay? And make sure you understand about that dyslipidemia, that it leads to atherosclerosis, hypertension, heart attack, and or stroke, right? So here's another one of our activities. I want you guys to pause this, read over this, and then write down, okay? And then if you're running into any problems, make some notes so you can send me an email. So now, like I said, in your textbook, and earlier I stumbled over when I was saying there's 2 types, because there are, there's pre-diabetes, and it's the state that occurs when blood glucose levels are higher than normal, but not high enough for you to be diagnosed with diabetes. And there's been studies out there that shown that type 2 diabetes develops in most people with pre-diabetes within 10 years. So if you can catch these people with this pre-diabetic condition before 10 years and get them to alter their lifestyle, you can prevent your patients from ever going into diabetes, okay? So when you see these patients come in, they're overweight, they're sedentary, and they're this always at that high normal, always at that high level, time after time after time, they're at a risk of becoming type 2 diabetics. You can delay that development of diabetes through weight loss, a diet low in refined carbohydrates. Remember, carbohydrates are not the devil, but you want to make sure that all those refined carbohydrates, things that don't have any fiber in them, these Polar Pops, some of them are 800 calories of these Cokes, this refined sugar, all these processed foods that are loaded down with sugar and sodium. You've got to get people moved away from that. And then regular exercise. And I'm not saying that you need to go out and bench press a bunch of weight or go out and run a marathon. Start walking your dog. Start walking in your neighborhood. Build yourself up to walking 3 miles in the evenings. Work yourself up to do some body resistance training. And get that weight off. Look at those refined carbs. Get all that junk of processed, refined carbohydrates, high sodium, high chemicals out of your diet and move over to a whole food, plant-based diet. So what is gestational diabetes? Because I said that's another thing. Gestational diabetes occurs during pregnancy, right? And so the mother's IGT usually subsides after delivery, okay, of the baby. Signs and symptoms of gestational diabetes include glucosuria, hyperglycemia, excessive weight gain in the mother, and a baby weighing 9 pounds or more. Okay, so women who have gestational diabetes are also prone to developing type 2 diabetes later in life, but it doesn't have to be that way. And I am living proof of that. I had gestational diabetes when I was pregnant with my daughter. Unfortunately, I had everything that could go wrong in a pregnancy go wrong. I gained a ton of weight, but this was, I was in my late 20s, and this is before I educated and informed myself on nutrition. Okay, so you can imagine somebody like me. I was a lab tech at that time. I worked in a hospital. But of course, this was the early 90s. And back then it was fat-free, fat-free, fat-free. Don't eat any carbs. But then what they were doing is they put bad stuff into that food, thinking that fat-free made us fat. But anyway, I wasn't understanding processed food. I wasn't understanding the importance of a whole food, plant-based diet. I was, burning the candle at both ends, trying to do as much as I could, and whatever was fast, quick, and easy. I consumed more meat than I needed to, and it made me unhealthy. And it's one of the things that I regret. I wish I could go back in time and do that over again, because I would have prepared myself for pregnancy, being much healthier leading up to ever becoming pregnant. Almost like laying your food is only as good as the soil it's grown in. If your soil that you grow your food in is not good, it's not loaded with good minerals in that soil, it's a good mineral soil, then your food is not going to have the minerals and nutrients in that food that it needs to be. And it's the same thing. I wish I would have laid a better groundwork for my pregnancy, because I think it just helps your baby. And then what you feed your baby once it gets here is vitally important. We want to start out from the day our child gets here, making sure we're prepared, we're informed and educated on what's the best things to feed our children. Okay? So this is all important. Okay? But I never, because I woke up one day and I changed to a whole food plant-based diet and I exercise regularly, and as I've aged, I've had to battle watching my weight even more, but I have never developed type 2 diabetes since I had gestational diabetes. So even though it's a telltale sign that you could develop type 2 diabetes later in life, what it's really telling you is there's something in your lifestyle that is not good, and it's a wake-up call. It's a warning for you to start looking at what you're eating, how you're moving, what you're doing, what you're drinking even, anything that you put in your mouth, and what you may need to do. Okay, then also there is transient diabetes. Individuals may have diabetes during an acute illness or when being administered steroid therapy. This form of diabetes usually lasts as long as the condition or the treatment continues, and then once they stop taking the steroids or they're not sick anymore, then a lot of times, if that was what was causing it, then they will go back to normal. But make sure you do understand there's a thing out there referred to as transient diabetes. So talking about blood glucose screening and monitoring, right? So there's fasting blood glucose, right? Blood sample is taken after about 10 to 14 hours of fasting. Nothing but water, right? We don't chew gum, we don't drink any kind of coffee, any kind of tea. Even if it doesn't have sugar in it, we don't smoke, right? So if it's you are diagnosed, if you are truly fasting, that's a fasting specimen, and you have a greater than 126 milligrams per deciliter glucose result, you are diabetic. If you have on 2 separate days 100 to 126 milligrams per deciliter, that's pre-diabetes. And remember, we talked about this. These are the people we want to catch. In healthcare, we want to catch these pre-diabetics, and then we want to talk to them. What are they eating? What's their stress levels? What's their activity level? You know, what are they drinking a lot of Cokes? Are they drinking a lot of alcohol? What are they doing that's causing this? Because remember, they can have pre-diabetes for up to about 10 years before it turns into type 2 diabetes, and we want to catch these people now because we can reverse things like heart disease, which is the #1 killer in the world. Okay, then we have that oral glucose tolerance test or the 2-hour postprandial, which means after eating test. And that starts with measurement of the fasting blood glucose as above, like we talked about above. Then patient drinks or eats a glucose-rich drink or meal, and we really try to get them to drink the drink, because then we are really controlling that they're getting that 75 grams of glucose. It's just much better than sending them off to eat a certain meal. It's just much more controlled and accurate. And then blood samples are taken 2 hours later. Okay, the patient is retested for blood glucose levels, which must be down to about 140 milligrams per deciliter. Okay, if after 2 hours they're at or above, because if they're close to 200, you know, but that's just not good. But if it's 210 above 200 after 2 hours, they are diabetic, plain and simple. If after 2 hours they're between 140 and right at that 200 level, that's our pre-diabetics, and we really want to get on top of those patients to prevent them from going into full-blown diabetes. Okay, so then there's just a random glucose test. The specimen is collected any time of the day or night. If it's above 200, you're usually a diabetic. If you see this at 140 to 200, they're usually pre-diabetic. And again, we want to take care of it. Excuse me. So then we have a glucose tolerance test. It used to be the gold standard and what we used to diagnose diabetics. Typically, that's really done with the hemoglobin A1C now. But this test begins with fasting blood and urine specimens taken. Of course, they need to be fasting. We usually get them to drink eat a normal meal for 3 days, just what their normal meal is for 3 days prior to it. And then they fast for anywhere from 10 to 14 hours before this. Then they come in, we do their collective fasting urine and the fasting blood sample, and then the patient to drink that glucose-rich beverage. And for adults, that's about 75 grams. And then specimens are collected and tested at the half hour and every hour for 2 to 6 hours after. Specimen times are calculated from when that patient finishes drinking that glucose-rich beverage. Okay, 200 or greater at or after 2 hours is usually what we diagnose them with diabetes. And then we watch patients for signs of fainting or nausea during this test. So here's another one of our case studies. Again, please pause this video, read through it, and make sure that you're being able to put this stuff together, because we want you guys to learn in lab and in lecture, be able to put all this stuff together so that when you're out there working as a lab assistant or as a medical assistant, you're able to really critically think through all the information that you've obtained, be able to piece it together, and be able to make decisions out there in the field. So, again, here's our question, right? So again, here's one of those slides. You guys read through this, make sure that you stop it and pause it, and make sure that you're putting this stuff together. We really want to be able to solve these cases. Okay, still we're talking about blood glucose screening and monitoring tests. Okay, guys, so we're talking about glycosylated hemoglobin, right? So what is this, right? Okay, so RBCs, okay, they have a lifespan. You know, they live for approximately 120 days. And during that time, and if you'll see from this picture over here to your right, you know, glucose will come into that cell, okay? And then that glucose plus that hemoglobin is glycohemoglobin, right? So whenever blood glucose levels are high, the excessive glucose clings to that RBC's hemoglobin, making it permanently glycosylated or sugared, okay? So the percentage of that glycosylated hemoglobin is directly related to the levels of blood glucose high, right, during the past 2 to 3 months, you know, which is about the average lifespan of an RBC. So glycosylated hemoglobin test is that hemoglobin A1C, and that's why I said earlier this really is the go-to test now for diabetes, okay? Because it measures the percentage of that glycosylated hemoglobin and provides an accurate long-term index of that patient's average blood glucose levels over time, or at least the life of that RBC, which is approximately 120 days, okay? So, and think of it like this, you know, and I've told this story before. So, your grandmother or your aunt, and I had a grandma that was diabetic, you know, they may be eating coconut cake and eating badly and doing whatever they wanted to do. And then about a few days or a week before they knew they had to go in to see the doctor, they cleaned up their diet. So that day when they went in, their glucose wasn't too bad. So, you know, the doctor didn't get on to them. Talk about eating the carrot cake and the pie and all that. But see, you can't lie your way through that hemoglobin A1C, because for a whole 120 days, it's keeping up with how many times those blood sugars went excessively high and attached to that hemoglobin in the red cell. Now, the reference ranges for a non-diabetics is 2.2% to 4.4%. Diabetics in control is 6% to 8%. Now, what you would really like to do is to reverse that diabetes and get back down to around that 4.4%, but we see this as an in-control diabetic when they're between 6% to 8%. So here's another one of our critical thinking slides. Please do what I said, guys. Read through these, pause them, be able to do your case studies so that you will know that you're putting together all the information you're learning in all your classes, and you're able to critically think through situations that you're dealing with out in the field. Here's an example of what I'm talking about. So the first thing you need to do from the information you were given is determine does she have type 1 or type 2 diabetes, right? Because 10 years old. Again, just like I talked about, Her diabetes had been out of control. She was doing whatever she wanted to do, eating whatever she wanted to do until a little bit before her visit. But she couldn't get away from that hemoglobin A1C result. And this is a game changer for us really working with our diabetic patients and really staying on top of them to make these lifestyle choices that they need, changes that they need to make sure that they're staying healthy and avoiding other issues that come with diabetes, like heart disease. So make sure that you're understanding that anything that goes into these tubes is an additive, and make sure you know which tubes are for what and what additives are in those tubes and what they're for. And like I said, anything that goes in that tube is an additive, but you need to know which ones are the preservatives, because we know that gray top is the tube of choice for our glucose. And which one is the anticoagulant that makes it not clot, which helps with turnaround time because we can spin it down immediately and run our glucose test. So really the best tube to use would be either one of the sodium fluorides with that potassium oxalate or a sodium fluoride with that EDTA, because not only do we have the preservative that preserves the glucose, but also we have an anticoagulant in there, so we can quickly spin this tube down, get our plasma off, and run our glucose results. So here's another one of our concepts that we want to be able to articulate this stuff in our own words, okay? We want to be able to understand this. The way you know you understand how things work is when you're able to describe it in your own words and explain what's going on. So make sure you guys are writing this down, okay? So you want to describe in your own words why the hemoglobin A1C test is called the tattletale test. Okay, so rates of obesity and heart disease are increasing in the U.S. like I've talked about, okay? And so we want to move on because, like I said, make sure that you're looking at that stuff in your book because, like I said, page 150, 151, a lot of great information. 152, just really, really good information. This will really help you on acing your test. Not only that, but getting all the knowledge you need to be the best medical assistant or the best lab assistant you can be. And you know, guys, you know I always talk to you guys about it. I want you to continue with your education, okay? And so really learning this stuff is going to help you if you want to move on and become a nurse, if you want to move on and become a clinical laboratory scientist, if you want to move on and become a respiratory therapist or an x-ray tech or whatever you may want to do. Making sure that you truly understand this. It's not going to only help you in the classes you're taking now, in your certification exams, in your job that you do every day, but also in your helping yourself, but in also if you want to continue your education, learning this stuff now will really give you that step up when you go back to school to become a nurse or a clinical laboratory scientist. Okay, so like I talked about, you know, when we started eating no fat, we started getting fat. And I talked about, you know, that moving away from whole food plant-based diet, moving away from getting exercise and sitting behind desk all day and being very not moving and all that has really not only raised the rates of type 2 diabetes, but obesity and morbid obesity, heart disease, cancer, and all that. So lipid screenings and monitoring are now recommended and approved as CLIA wave tests because we want these CLIA wave tests are really important when we're talking about being able to quickly diagnose patients and then being able to quickly monitor them. You want to monitor, like I said earlier, that handheld glucose monitor like that AccuCheck, that was a game changer for diabetics. because it was a way for them to regularly check their glucose, to know if they need more insulin or less insulin, to know, if their blood sugars are getting high and if they need to see their physician. It is really a good way for them to monitor their disease state and be able to properly treat it. The same thing, because like I said, right now, heart disease is the leading cause of death globally, right? And so what we need to understand with heart disease is that cholesterol and triglycerides are things that we need to monitor so we can better treat our patients, okay? So still talking about lipid metabolism, and like I said, in chapter 6, page 153 of your textbook, it talks about lipid metabolism and testing, right? Lipids or fats, they are essential to the body. Again, carbohydrates are not the devil. Fat is not the devil, okay? We need to eat a well-balanced meal. We need to make sure that we're getting healthy fats in moderation. We need to make sure that we're getting the carbohydrates we need. We need more complex carbs, and we need protein. But we need to make sure that we're also getting very nutrient-dense food like fruits and vegetables, and that we are paying attention to the calories we're taking in versus the calories that we're burning, right? So research has shown that poor lipid metabolism and cardiovascular disease are directly linked, right? So in an effort to help connect the growing problems of obesity and heart disease in the U.S., annual lipid screenings and monitoring tests are recommended. Lipid screening, as I said earlier, is approved as a CLIA Wave test. So what happens to fats during digestion? So fats are broken down into fatty acids in the liver. Fatty acids are reassembled into a variety of lipids that serve as severely essential functions, right? So like I said, carbohydrates are not the devil, fats not the devil, right? So, and it starts with just the ingestion of our fats, right? Dietary fats and oils are digested into glycerol and fatty acids, which are transported to the tissues where they are further broken down and can be used for energy, right? Some of the essential functions and uses of lipids are shown right here in green, right? Okay, so we need fats to produce steroidal hormones, right? They transport fat-soluble vitamins, because we have water-soluble vitamins and we have fat-soluble vitamins, okay? That's why we don't worry so much about the amount of water-soluble vitamins that we take in, because once we get to that threshold level where we've taken in as much of the water-soluble vitamins as we need, we will just urinate those out. We do need to be careful with the amount of fat-soluble vitamins we take in, and we need to know what those are and watch them, because as our fat stores build up, so can the amount of fat-soluble vitamins in our system, and they can become toxic. That's why you need to be careful. More is not always better, okay? It helps with the maintenance of body temperature and healthy skin, protects vital organs and nerves, and it can serve as an energy source when glucose is not available. Okay? We all want some amount of fat. It's healthy to have some amount of fat, but we just need to know for our height and weight what is a healthy body fat composition for us, okay? And we need to try to maintain that. It can also satiate our feelings of hunger, and that's a good way for us to help us lose weight and maintain healthy weight. So cholesterol, right? And again, guys, you can follow through. There's a lot of great information in our textbook. Remember, cholesterol is found in all cells of the body and is a major constituent of cells, membranes, in the myelin sheathing of our nerves. Cholesterol is also required in the production of vitamin D. Okay? Most of the cholesterol found in the body is manufactured in the liver and is called endogenous cholesterol. Okay? In fact, the liver is able to produce all the cholesterol your body needs. So we have endogenous cholesterol and exogenous cholesterol, right? Okay, so one, endo, right? EN sounds like in the liver. It's manufactured inside the body, right? Manufactured into the liver. Think X, out, exit, right? it is obtained from food sources, okay? So saturated fats come from meat, eggs, and dairy and raised cholesterol. Trans fats come from man-made hydrogenated margarines and oils, and they raise cholesterol, okay? So make sure you know about saturated fats, trans fats, and like I said, there's a lot of good information in your textbook, because it talks about that not all dietary fats have the adverse effects of saturated fats and trans fats, okay? Research has found that monounsaturated fats and polyunsaturated fats, which are naturally liquid at room temperature, actually lower the blood level of cholesterol. These may help reduce plaque buildup on the blood vessel walls. Examples of good monosaturated fats are canola oils, olive oils, omega-3 oils from fish, and a lot of seeds and nuts like almonds and flax seeds. These are all things that, in moderation, again, you have to be careful with avocados and almonds and things like that, because they're very calorically dense. They're very good for you, and they're a good source of healthy fats. And like I said, fat is not the devil, okay? We just need to, like I talked about, eating the right types of carbohydrates. We need to eat the right types of fats. But we need to pay attention to the amount of calories are in just a very small amount of healthy fats, because a way to maintain a healthy weight or lose weight so that we can get to a healthy weight is watching the amount of calories we take in versus the amount of calories we burn. And we especially want to avoid these fats that cause buildup of plaque in our arteries, which can lead to heart attacks, and strokes, okay? So, and we talked about this, you know, all right? So we want to make sure that we look to those healthy monounsaturated and polyunsaturated fats. And again, if you're using something to cook with that is at room temperature, it's a solid form, you want to stay away from that. You want to try to worry about those oils, but be very careful. Look at those labels, okay? Make sure you read those labels. There is a lot of calories in olive oil. There's a lot of calories in canola oil. And I'm not saying that you shouldn't use it, but you need to be sparingly with it. And when you're talking about eating avocados, great source of healthy fat, great thing to eat, but be careful. How many calories are in it? How many calories are you taking in, and how many are you burning? And you especially want to avoid bad fats that help build up that plaque in your arteries, and you want to avoid those carbohydrates that have no nutritional value, that have no nutrients in them, that have no fiber in them. Those types of things are not good for you. So talking about lipoproteins, okay, so cholesterol and triglycerides are lipids that do not mix with the water in your plasma, okay? Consequently, the liver attaches a protein to these lipids, which then becomes lipoproteins, okay? There are 3 types of lipoproteins, and they're manufactured in the liver and are classified on the basis of their density, okay? So remember, lipids plus protein equals lipoprotein, right? And the liver does that job of binding those lipids, such as that, like we talked about, cholesterol and triglycerides, to that protein, so that that lipid, which won't mix in the water in your plasma, can be transported in the bloodstream, because our bloodstream is approximately 90% water. So you can see where we wouldn't be able to transport these lipids from one place to the other if our liver wasn't able to, for lack of a better word, package them with that protein to make them able to be transported, okay? So, like I talked about, there are 3 types of those lipoproteins that are manufactured in that liver. Remember, and I talked about that they were classified on the basis of their density, right? And so we have HDL, right? High density lipoproteins. These are stereotypically, referred to as good or healthy cholesterol because they remove plaque from our arteries, right? Which we do not want plaque in our arteries. Then we have what a lot of people refer to as low density lipoproteins, LDL, which is bad or lousy cholesterol because they can form fatty plaque on the walls of our arteries, and we don't want that. And then there's very low density lipoproteins, which are very lousy, right? These are just ways for you to learn this. Very, very lousy, right? Lousy, bad, right? Triglycerides. So remember, these are our three categories of lipoproteins based on that density, right? Based on what they do. And the reason we call them good is because they remove plaque, and the reason because we call them bad is because they help build up plaque. And plaque in your arteries, bad, can lead to strokes, can lead to heart attacks, right? So total cholesterol and divided by like that high density lipoprotein ratio, right? So what laboratory values is the best predictive indicator of the possible future of you having a myocardial infarction or a heart attack, right? Well, what we like to look at is that total cholesterol divided by the HDL value, right? And a ratio under 4.5 indicates that most of the total cholesterol is made up of good HDL. A ratio of 4.5 indicates that not enough HDL is being made. Okay? So total cholesterol divided by HDL in a ratio under 4.5 should be the patient's goal, right? Because we want most of our cholesterol made up of that high density lipoproteins, right? So now we went through all this, right? And now we want to see if we're putting this all together so that as medical assistants, as lab assistants, we're able to go out into the field and put this together. So go through this, pause it, write down your answer. Again, if you're not putting this stuff together, if you have any questions, comments, or concerns, please reach out to me. I hate we're not in class and we can't just pause this and ask questions, but you guys can reach me at any time. Okay, again, if you had any questions with this, if you don't understand, please reach out to me and ask me. I'll be glad to help you guys. Okay, still talking about lipoproteins, right? So what are some ways to increase HDL levels and lower LDL levels? Okay, because that's our goal, right? That's what we want. If we want to be healthy, and so that not only can we live a longer life, but we can live a better quality life. It's one thing to grow old and be in a wheelchair or not be able to do anything. You can't breathe, you can't go anywhere, you're just laying in the bed at home watching TV. But what we want to do is be able not only to live a long life, but to live a good quality long life. And one of the ways we can do that is by avoiding one of the #1 killers in heart disease, stroke, that type of thing. And the way we can do that is exercise, right? #1 thing. And that's what I'm talking about, guys. Whole food, plant-based diet, making sure you keep your stress levels as low as you can, and getting plenty of rest. We need to get at least 7 to 8 hours of sleep a night. Making sure that we're eating nutrient-dense food, understanding how many calories we're taking in. You'll be surprised sometimes. You don't realize the little things you're adding to your food, like olive oil, like your coffee creamer, like the Cokes you're drinking, or that alcoholic beverage you're having. Those can add a ton of calories, and then you're ending up taking in a whole lot more calories than you ever thought you were. And because you're not exercising, you're not burning those calories. And then you build up that fat, and then you put yourself in a state of being pre-diabetic. Now, exercise not only can help you increase your HDL level and lower your LDL level, it can help you maintain a healthy weight. It can strengthen your cardiovascular system. It helps with, its research has proven it helps with anxiety. It helps with depression. It makes you feel like you have a lot more energy. It can help you with your bone density, so you have stronger bones and tendons and muscles. So guys, exercise is important. If you don't have an exercise routine at this time, of course, we always want to talk to our physician. We want to know our level. We want to start out slow and build up slowly. But if nothing else, get out there and start walking. Right now, a lot of us are trapped in the house. You can't go anywhere and do anything. Take a break. Go out and walk around. Breathe in your fresh air. Get some sunlight for that vitamin D and get moving and get your steps built up. If nothing else, get a step counter, get a watch. Everybody get one of those Apple Watches or Garmin's or whatever you need and see how many steps you're getting in a day. And so start trying to play a game with yourself to increase your steps, because that's going to increase the time that you're moving around, will help you. Also, as we've talked about throughout this, diet with good polyunsaturated and monounsaturated fats, diets with good carbohydrates, whole grains, high fiber, cholesterol lowering medications, if it comes to that, like statins. And what I really would like to see people to do is to use food as your medicine. Now, that can't always happen, but if we start out young and we're getting our exercise in and we're eating a whole food plant-based diet and we're making sure we're eating healthy fats in moderation and healthy carbohydrates and we're exercising, we really can early on really increase our chances of lowering the chance that we have to take any type of medication. Okay, so moving on to triglycerides, okay? So again, guys, make sure you're reading your textbook, okay? Following along, okay? Make sure that you know, read this. A lot of really, really great information in that textbook. So what are triglycerides? Okay, so triglycerides account for about 95% of the fat stored in the adipose tissue, right? It's transported in the blood plasma. It's LDL and VLDL, right? Low density lipoproteins and very low density lipoproteins, both bad, right? Bad, 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 lousy, 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 right? So the direct result of diets high in carbohydrates, the bad carbohydrates, when I say bad carbohydrates, I'm talking about processed foods loaded with refined sugars, added sugars. You know, an apple is sweet. It has sugar in it. But it's also an apple. If you eat it whole, it has a lot of fiber, which evens it out. You don't want to avoid the sugar that's in fruit. Okay? Fruit is good for you. Blueberries, strawberries, okay? High in water content, high in fiber. You want to avoid Coke, which is loaded with processed sugar and there's no fiber in it. Alcohol, sugar in it. You know, all these things need, I'm not saying you can never drink a Coke. I'm not saying you couldn't have a beer or a glass of wine, even though, you know, the healthiest way is none at all. But you really need to keep a count on it, not for just the excess calories you're taking in that you may not be burning, but because of that low density lipoproteins and very low density lipoproteins. So how should the patient be instructed prior to triglyceride testings? Okay? So the patient must fast for 12 to 14 hours and have no alcohol for 48 hours before testing. Okay? And you need to know this because you as medical assistants and even lab assistants, phlebotomists out there, you're going to be informing these patients on what they need to do before they come in for their next visit. And you want to make sure they understand that these are the things they need to do so we can get some spot-on, accurate results, right? Because we're diagnosing, monitoring, and treating our patients based off these laboratory results, okay? So what does the plasma look like with hyperlipidemia from a high triglyceride level, okay? It has a very opaque white appearance, and I've showed you guys this in the lab. It really, when you spin the tube down, instead of you having that straw colored plasma or serum up there, you can't see through it, and it looks like milk. And that's from that high levels of triglycerides, and it's hyperlipidemia, and that you do not want to see that in your patients, in your cell anywhere, okay? So talking about the lipid panel of tests consists of total cholesterol, HDL, LDL, VLDL, triglycerides, and the total cholesterol divided by the HDL ratio, right? And so here is our ranges that we want to stay in, right? So for our total cholesterol, we want it to be lower than 200 milligrams per deciliter, right? HDL greater than 40, LDL less than 100, triglycerides less than 150, and 4.5 or less for our total cholesterol HDL ratio, and that's a very important number, okay? So make sure you're reading your that page 154 down at the bottom about the lipid panel. So the analysis of the lipid panel determines cardiac risk, okay? We always want to know what our risk factors are, right? And everybody talks of genetics, you know, my family, everybody in my family is fat. Well, I'm not saying that genetics cannot predispose you to things like cancer, high blood pressure, and obesity. Even can leave you predisposed to addictive behaviors like smoking and drinking. But they're only a piece of the puzzle, and you do not have to fall prey to your genetics. You can lower your risk of these things by making sure you're not doing things like eating a high processed, high sodium diet. You're not moving. You're sedentary. You're smoking. You're drinking too much. You're eating the wrong foods. You're not moving, and you're gaining weight. These are all things that are a risk. Your height to weight ratio, your blood pressure, and if you are a smoker, all increase your risk of a heart attack. So here's one of our things. Make sure you pause this and look through it, guys. So still talking about clear wave chemistry tests. So are blood chemistry tests quantitative or qualitative tests? Okay, they're quantitative, right? In the fecal occult blood test, quantitative or qualitative? It's qualitative, right? So quantitative, quantity, that's a number. Where you at least get some type of number or range number, that is a quantitative test. When you look at that test and you say either the color shows up or the color doesn't show up, a positive sign shows up or a negative sign shows up, you're not getting any type of number, whether it's a quantitative or semi-quantitative. You're getting no range of numbers. You're just getting something that you see happen, a reaction. That's that quantitative test. So in page 155 in our textbook, it goes through the principles of photometry. A spectrum of light passes through the specimen and strikes a photodetector. The intensity of the light received by the photodetector is then sent to a readout device that is able to convert the light intensity to a quantitative concentration of the analyte being tested. The concentration of the substance is directly proportional to the amount of light being absorbed at the particular wavelength. And that's based on the Beer-Lambert law, okay? All right, so they measure the amount of color change that's caused by the reaction of the particular analyte that we're looking at, okay, such as glucose or lipids, with a reagent that is placed into that tube. So you put some of the serum or plasma in the tube, and then say we're looking for glucose, then we're going to put a specific reagent that is going to react with that glucose that's in there into that tube, mix it up, shine the light through it, and the color change is measured directly by that light that's passing through that specimen. And then for the photometry, and then indirect by light absorbed or reflected off the specimen, and then that's when it's sent to that readout device and you get a number, okay? An example of transmittance photometry is the lipid profile on the Cholestex instrument. And I'm going to have something up online about the Cholestex instrument dealing with your lab portion of your class. And also an example of reflectance photometry is a glucose test like the AccuCheck, those handheld glucose monitors. But guys, there's a lot more detailed information on page 154 and 155 in your textbook. Make sure you read that. Make sure you're filling out your study guides, and make sure you understand how this works, okay? And earlier, like I told you, it's based on the Beer-Lambert law. So, and you look at the Beer's law, the concentration of a solution is directly proportional to the amount of light absorbed by the solution. So, if it states that the amount of color change is directly proportionate to the amount of analyte within that specimen. So, and there's this picture is inside our textbook on page 155, and you want to describe how the path of light works its way through a photometer, okay? You have your light source, right? And you want to make sure you know how, then I talked about this, how it strikes the photodetector, and the intensity of the light is received by the photodetector and it's sent to a readout device, right? So, and that gravimeter is usually that readout device that you see. So make sure you go through this and you understand, and like I said, a lot more detailed information on this is present in your textbook, because you've got to understand the chemical analyzers used in blood chemistry testing are highly sensitive photometers and spectrophotometers that directly measure the amount of light passing through that solution, right? And so, you know, make sure that you understand each one of these processes and how this works, because a lot of these instruments are based off of this the way this works, right? And we're talking about photometers and spectrophotometers, right? Okay. So we worry about quality assurance, right? Used with optical chemistry instruments. So each day an optics check and or calibration check must be run and logged to ensure that the instrument is working properly with the reagents, right? And we also want to make sure not only are we doing an optic check, but anytime we run any test, we do QC, right? QC is run every 8 hours each day of patient testing, right? And even though there's usually 3 levels of controls out there, low, normal, and high, CLIA says that we must run 2 levels of liquid controls of known value, right? And they're logged to make sure that what we're analyzing is accurate, right? We need to make sure we pay attention to expiration dates of both our reagents, our strips, our controls, all this, and that whatever storage temperature they're supposed to be stored at, they're being stored, right? And we always check the temperature of our room. We check the temperature of our refrigerators, freezers, our incubators, to make sure that all those particular pieces of equipment are at the correct temperature as well. And we must always read the current package inserts for controls, supplies, kits, and all that. And we must retain them for reference, because you never know when you might want to look back at those things to make sure that you're doing it the correct way. Here's another one of our higher learning activities, so make sure you pause this, read through it, and make sure that you're putting all this stuff together, guys. Okay, we're still talking about CLIA wave glucose testing, okay? So we've seen this picture before down there at the bottom. That's an AccuCheck machine. You see the strips in there and it's got a readout, and then you see at the top there's a different kind of AccuCheck machine that there's a lot of them out there, and you see that they have their gloves on, which is vitally important. And they have done appropriate finger stick, which they would have never been holding that finger in their hand as they were using the lancet on the finger. But once they stuck the patient, wiped off that first drop of blood, then they can pick their finger up, push on it, produce that big, fat, pregnant drop of blood. And then, as you see right here, you can see right here at this tip end right here is where you're going to touch that drop of blood to that, And by capillary action or attraction, it's going to pull in the amount of blood it needs. And if you have a good, nice, round drop of blood there, it will pull it right in there. It'll make a beep sound. These are really easy instruments to use. And then it will count down and give you your results. So, so we want to talk about, there's lots of different brands out there, like I said. And the one we use at BIPSI, okay, is the Contour, okay? We use the Contour presently at BIPSI. What type of sample should be collected? We always use capillary blood for this, right? Do liquid controls have to be tested, logged, and analyzed? Of course they do. We always want to do that. Does an optic checks have to be run and logged? Yes. We always want to make sure we do all our maintenance, calibrations, and QC. We want to make sure that these instruments are working properly before we run our patients on them and report out our lab results. Okay? So, what is the name of the clear wave instrument used to test the hemoglobin A1C? The one we use at BIPSI is the DCA 2000. Okay? Again, this is an instrument that's clear wave that's usually used in physicians' office labs. So most of the time, as with this one, it's capillary blood from a finger stick that you're going to use. Okay? And as always, we always want to run controls. Liquid controls, 2 levels of controls, are run every 8 hours or anytime you've run a patient. And you always want to do all maintenance and optic checks. And all this stuff not only needs to be ran, but it needs to be logged, right? If you don't write it down, it didn't happen. Okay? So, you want to be able to name the clear wave glucose test, okay? So, we have fasting glucose test, okay? These are all the tests that we have, but that fasting glucose test, right? The random glucose test, that oral glucose test, the OGTT, or the 2-hour postprandial test, the glucose tolerance test, and the glycosylated hemoglobin, which is the hemoglobin A1C. Okay, so still talking about this instrumentation, and you'll see a lot of different types of instrumentation. There's a lot of great information in your textbook, page 156, 157. The Contour is on procedure 6.1, and it goes through all the equipment you need, patient specimens, and procedures. You guys look over this. It's very vitally important, okay? It gives you a lot of great information with some really, really good pictures, okay? So look at that on page 158, 159. Goes through, you can look at different kinds of tests all through your textbook. So right here is the CollectTech LDX, which is the instrument we use at BIPSI, right? And on page 162, procedure 6.3, there it shows you all the parts of that, everything that you would use, some great pictures, great information about this CollectTech. And it's a much bigger picture so you can see it. So look to your textbook, page 162, right? So again, as with physician's office lab tests, these clear wave tests, we use capillary blood from a finger stick. We always run controls, we always log them, and we always do our optic checks and log those as well. And it shows you running the optics checks on page 163 of your textbook, okay? So we want to make sure, oh Lord, low battery, hold up guys. Okay, this is one of our learning activities, right? So you want to be able to pause these and go through them. So you want to tell which of the following are glucose test or lipid test. So guys, really pause this and go through it and make sure that you are getting what the difference is between the ones that are testing for, that are our lipid test, to test for that type of issue, and the ones that's for our glucose test for, we're looking for prediabetes, diabetes, gestational diabetes, and those types of things. And make sure you understand these values. Now, this takes time. Start studying these values now so you will understand what, because you need to, at a glance, know. Now, I will say that most of your printouts, most of your requisitions form are going to have your normal values on there, but I promise you, you're going to learn them after a while anyway. So go ahead and start learning them now so you can get it in your mind so you can be able to quickly see if your patient is in or out of range, right? Again, here we are with some more normal values, and you guys are going to not only need to know this for the test, but this is really something that as you go through, these are things you need to know. You're going to be looking at these lab results. You need to be able to spot issues with your patients. So now moving on to fecal occult blood testing, okay? All right, so you want to describe the principle of a fecal occult blood test, okay? The Goddard method. So it is a qualitative test, remember we talked about this earlier, for the presence of blood that may not be visible to the naked eye. That's where the occult comes from, in a stool specimen. And so if you'll notice right over there to your right, okay, there's someone with it, they're applying, looks like they're putting the reagent onto it. Right above that, over to your right, is all the little pieces that come with the kit. And then down there at the bottom, that very last picture, over to your far right is a positive occult blood, and the one over to your left is a negative occult blood. So you can see this is a qualitative test because you are just looking for a color change. You're not getting a number on this, right? And what is the patient's preparation for this test? So if you are if you're going to send your patient home and they're going to come back and on their next visit you're going to run an occult blood or whatever, you want to make sure that the patient should be instructed to follow a special diet. Prior to the test, avoid red meats, turnips, horseradish, bananas, non-steroidal drugs such as inflammatory drugs, aspirin and iron, and anticoagulants such as Coumadin or warfarin. Okay, now page 169 in your book, it goes over the supplies you're going to need, the test procedure, and exactly how you do that occult blood. But of course, you can always use gloves, right, when you're doing this, and you're going to observe universal precautions, and that you're going to confirm that all the necessary information was written on these slide covers that you see up there, right? So if the patient collects it, they're going to collect 3 consecutive stool samples. Should be collected using 2 different spots on the stool, okay? And so then, and I went over you guys what that positive test looks like. It's indicated by the blue water-like mark around the stool sample after the developer is added. Okay, so, and you'll see, like I said, on page 169, and if you were in the hospital, what they would do is the back of that card is where they take, and if you saw in that first picture at the top where it showed all the stuff that came with it, it had some little wooden applicator sticks. You use those wooden applicator sticks to get the stool specimen and then put the specimen on the back side of that card and then close it down, right? And then there's a white mesh layer between that back side where the stool is and the front side where you open up that card. And if you notice, and on page 169 of your textbook, you'll see it, there's a little orange square with 2 little dots. And on page 169, one dot is blue that looks just like a positive, and the other dot is not. That's your control. That's your internal control that you need to do. And if that control does not work, one's negative, one's positive, then something's wrong with this card or something's wrong with that developer. And so you wouldn't want to report out whatever results you got from this card. You would need to get another card because something's wrong with that card. So then you follow directions by you open the back sides of all 3 slides and you place 2 drops of developer on each of one of those little specimens. Any blue reaction in the specimen area indicates a positive result. A positive result may be read in as early as 30 seconds to 2 minutes, but do not record a negative, no blue, until at least 2 minutes have passed. So remember that. If it turns blue quickly, you can record that after 30 seconds, but you want to rate the full 2 minutes to make sure you call it a negative, right? You also perform the monitor test, that internal control that I was telling you about, by placing 1 or 2 drops between the monitor boxes and waiting 30 seconds to 2 minutes to read the results and confirm that the positive turned blue and the negative did not. And again, if that does not work, something's wrong with the developer or that card, and you do not need to turn out the results off that patient. So anyway, look at that, and you can pause this higher learning activity and make sure you're putting together everything that you're learning and be able to make those decisions out in the field. So moving on to metabolic panels, right? Okay, and guys, make sure you're looking in your textbook. There's so many good pictures and information in there that really will help you as you're going through this. Okay, so talking about metabolic panels, basic and comprehensive, right? Not all offices can afford the previously described. I'm going to talk to you guys about some advanced stuff, and not all doctors' offices can afford that, right? So a panel or profile is just a group of related tests performed together, okay? Most panels are not CLIA wave tests, and blood must be drawn in red, green, or SST and sent to the reference lab. And remember, there's only one profile or panel that cannot be drawn in all 3 of them. Remember, that's the thyroid panel, right? Okay, so your electrolyte panel. Tests that measure positively charged cations and negatively charged anions. And in the electrolyte panel, you're doing sodium, potassium chloride, bicarbonate, carbon dioxide, right? For the renal panel, okay, sodium, potassium chloride, carbon dioxide, and then we add to that electrolyte panel, for it to be a renal panel, that albumin, calcium, phosphorus, glucose, creatinine, and a BUN. Okay, so we need to learn what's in these panels, right? So here's our chemistry panel, and here's our hepatic panel. Okay, and these are really good, especially every year if you go in for your checkup. It's really good to do one of those really good big chemistry panels that test for everything, because we really don't spend enough time doing preventative health out here, and what we really want to do is make sure we catch things before they get bad. We want to see our cholesterol as it starts to climb up very slowly. We don't want to wait till it's sky high. We don't want to wait till we're diabetic. We want to catch these things early so that we can do some things to stop it from getting any worse, right? And doing a comprehensive chemistry panel at least once a year is a really good way to catch anything before it goes wrong. You also have cardiac panels that they do if they're thinking a patient may have had a heart attack. And if you're having issues with your thyroid, as I once did, they can do a thyroid panel to check and see if your thyroid is overworking or not working enough, whether you have hyper or hypothyroidism. So again, these are those key terms. I'm going to go through those just really quickly because we went through these already, but these are vitally important for you to know, and make sure that you fill out your study guides and your studying needs, right? Okay, so I don't expect you guys, these lecture videos are very long, and I understand that, because if we were in class, I wouldn't lecture for 2 solid hours, right? So we would never able to cover usually an entire chapter in one class. But you can pause these, you can go back, you can rewind, you can really use these slides to, along with your textbook, to be able to fill out your study guides. And remember, we talked about plasma and its components and blood. We talked about those proper specimen collection for chemistry tests, right? Because, you know, IDing your patient, making sure you properly collect your blood, make sure you label it properly. This is all vitally important because we're putting out these lab results that not only are our doctors, our physicians, they're diagnosing our patients with them, but they're monitoring and treating those patients as well. So we talked about that basic principles of glucose and fat metabolism, which is not only important for us to know so that we can help our patients, that when we're medical assistants out there taking care of people, but also so we can take care of ourselves, right? And so we know what's going on. Also, if we're going to forward on with our education and go further in our careers, these things are vitally important to understand. We talked about all the different types of CLIA wave testing for glucose, such as our hemoglobin A1C, and all the glucose tolerance tests. And then we talked about lipid panels. We talked about that fecal occult blood and how that's a qualitative test because we're just looking for that color change. And we talked about Beer-Lambert's law on photometry, and we talked about tests included on different types of chemistry panels. Okay, guys, so this is a little bit of a review from here. I'm going to move through these slides pretty quickly here. You can pause them and take the time to see if you're able to answer these questions correctly, because the ones that you're weak on means those are the ones that you need to go back and study more for your upcoming test, right? And remember, I'm going to put up 6, 7, and 8. Your next test will be on chapter 6 and 7 in lecture. You will not have a separate test for chapter 8, but you will be responsible for reading, watching that video, filling out the study guides for that test, reading that chapter and studying that, because it will be on your comprehensive final. If you have any questions, comments, or concerns, make sure you reach out to me, okay? Remember, pause it when you see this green wording. Go ahead and pause it and see if you're answering these things correctly. Okay, guys, like I said, it takes me a little bit longer because like I said, if I would be lecturing in class, chapter 6, it would have taken 3 days, 3 different classes, maybe 4 to get through that. But we can do this all at one time, but it does take some time to not only record it, but also then to export it and upload it. But start watching these videos, reading the chapters, filling out your study guides, and I will start on chapter 7 next, and then 8. You guys, I hope you're doing well. Everybody's staying safe and healthy. And if, like, again, questions, comments, and concerns, please reach out to me. And remember, you know, today is, I'm filming this today, Friday, April the 17th. Remember, I know a lot of people in my Allied Health 209 are graduating, and I'll make sure I have y'all's grades in first, so that nothing goes wrong there. But if you are signing up for any classes for the Maymester, for the summer, or for the fall, remember, Maymester and summer has been open. Registration's been open for a while, and Wednesday of this week, the 15th, I believe, if I'm saying that right, the 15th, that Wednesday, the registration for fall open. So if you know anybody out there that's like, hey, you know, I need to register for classes, I don't know what's going on. Hey, BIPC's open, we're working. So we're registering. If they can go online to bpcc.edu and work through it there, and they can sign up for classes. If they run into any problems, they'll be able to email an advisor. They'll help them. If they run into issues and you're trying to help them and y'all can't figure it out, hey, give them my email address, and I'll be glad to lead them in the right direction. So again, guys, I miss you guys. Y'all take care, and let's get started studying for that next test. Have a great day.